Hi, this is Dr. Michelle O'Donoghue reporting from Medscape. Joining me today is Dr. Rachel Bond. She is the Systems Director for Women's Cardiovascular Health at Dignity Health in Arizona. Thanks for joining me today, Rachel.
Thank you so much. It's a pleasure to be here.
So you're going to be talking about at this conference the issue of cardio-obstetrics. And I'm so glad that this topic is finally getting the attention that it deserves, because for far too long we have not been incorporating obstetrics into a woman's cardiovascular history.
Mm-hmm.
And really it should play a key part. Yeah, what are your thoughts about, I suppose really what should doctors be asking patients when they're trying to understand what their cardiovascular risk factors are?
Yeah, no, that's a wonderful question. And you're absolutely right that it's such an exciting time in the world of cardio obstetrics. I would say, particularly for this year, it's so timely with us realizing that cardiovascular disease is something across the lifespan. And we know that a key part during a woman's age is reproductive health if they do decide to have a child. With that being said, when it comes to us as cardiologists, it's such a pivotal part that in addition to the traditional history that we take, which looks at those traditional risk factors like high blood pressure and high cholesterol and diabetes and smoking history, things that actually do disproportionately impact more women than men. As an example, we also have to think about cardio-obstetrics. We have to think about the reproductive health of that particular patient. So during their pregnancy, did they have gestational diabetes, gestational hypertension, other hypertensive disorders of pregnancy, such as chronic hypertension, meaning blood pressure being diagnosed prior to 20 weeks gestation, or even preeclampsia? And we even know premature labor and having a child smaller than gestational age. These are all independent risk factors for cardiovascular disease. And what we're noticing is that it can actually impact a woman's health about 20 to even sometimes 40 years after their delivery. So it's such an important part for us, if we're going to really think about caring for the patient as a whole, to incorporate that standardly into the medical history.
That you made a lot of great points, and I think one of them is that that they do appear to be independent risk factors for developing cardiovascular disease. And I emphasize that because I think there has been the misconception that you don't really need to ask people about a history of gestational diabetes or preeclampsia, because really those same individuals already have cardiovascular risk factors that you'd be identifying otherwise. So, once you ask somebody if they've ever had a diagnosis of high blood pressure, then you're covered. But I think what we're beginning to understand is that during the pregnancy, there might be actual biological changes that occur for people who have these complications that then put them at higher risk of developing cardiovascular disease down the road. Oh, tell us a little bit more about that.
Yeah, so although you bring a very valid point that although women that have these higher traditional risk factors are more likely to get those adverse pregnancy outcomes, we know that in a subset of the population, you may not necessarily have those traditional risk factors like the diabetes, the high cholesterol, or even the high blood pressure. Before I delve deeper into the independent risk factors and the pathophysiology behind that, I do think it's important to highlight that adults of reproductive age have less than 1% of ideal cardiovascular health. So this is why there's a misconception that most people that are going to have adverse pregnancy outcomes are coming into the pregnancies with lack of ideal cardiovascular health. But as noted, we know that those risk factors can occur with or without ideal cardiovascular health. As such, what we are trying to figure out is what is the underlying pathophysiology. And although it's very complex and complicated, we know that it is at the level of the endothelium. With pregnancy, independently, its own stress test, right? We think about pregnancy as a cardiac stress test, and we know that the changes that occur during pregnancy, just with our stroke volume, cardiac output, heart rate, blood pressure, etc., all of that could sometimes unmask at the level of the endothelium underlying conditions and underlying disease. And that can actually continue on into the entirety of decades, multiple decades later. So what we are really trying to emphasize is that these are risk factors that are independent of those more traditional risk factors, even though those more traditional risk factors put women at a higher risk of having these adverse pregnancy outcomes.
Yeah, I think it's such an interesting concept that really pregnancy is the early cardiac stress test and really may unmask future problems down the road. I have to say, from a personal angle, I developed gestational diabetes despite the fact that I think I'm probably the world's healthiest eater. And at least I fancied myself as being, exceedingly low risk for developing that type of complication. But it has made me more aware as a consequence. So if somebody is diagnosed during their pregnancy with one of these complications that we're discussing, what is the next step? Do you think that they should just be, more rigorously followed? Do you advocate sort of earlier initiation of statin therapy? How should doctors think about this?
Yeah, so right now we are actually looking for more research that's focused on this area, because although our assumption is that we need to be more rigorous, we don't have guidelines out there. What we do have are at least statements that give us suggestions on what that path should look like. So as an example, anybody who's had an adverse pregnancy outcome at a minimum should be screened for cardiometabolic risk factors at least 3 months after the delivery, at a minimum, possibly longer than that, depending on obviously the patient individually. But the recommendation is that screening should occur within that 3-month window, where we would be vigorously looking at the traditional risk factors that we can modify, like the blood pressure, the cholesterol, the diabetes risk, and really counseling them on healthy eating habits, exercise, all of the things that we typically would for the traditional risk factors. But more importantly, we now know that a lot of studies are looking to see if we should be also adding additional risk enhancers, sometimes biomarkers that can give us a better idea as if the risk is higher, or even the utilization of a calcium score. As an example, should we be screening these women later in the future with calcium scores to see, do we already see that there's subclinical evidence of cardiovascular disease? There was a large trial that came out that showed that women before the age of 45 actually had a much greater burden of pre-subclinical calcification in the coronary arteries than those after the age of 45. So with that being said, it gives us an opportunity to say that we probably should be more vigorous in terms of not just screening these patients, but possibly also initiating preventive measures such as these guideline recommendations, statin therapy and others, to really help reduce their risk of a cardiovascular disease, and more importantly, their burden of cardiovascular disease.
Yeah, because I think all too often people fall through the cracks.
Yes.
Because there are a lot of women who, in fact, don't even have a primary care doctor, and they view their gynecologist or their OB as really their healthcare provider. And then, whose responsibility is it, I suppose? Because I think once the baby's born, very often, you have your final visit with the OB, and then I feel that there is opportunity for people to fall through the cracks at that point in time.
And that is the concern, that sort of the gaps in care. And what we are really trying to do is to change the way medicine has been practiced in the past, which is more siloed, and really allow for that collaboration. So you're absolutely right to say the obstetrician gynecologist tends to be the primary care clinician during the reproductive years. But in an effort, there is a lot of education that will be targeting the obstetricians, but in an effort to also ensure that there's longevity in the screening, we really do need to ensure that they are handing that patient over to either the primary care clinician and possibly even cardiology, if cardiologists do need to be involved. And that's really at the discretion of the patient's individual risk, because it's important for even primary care clinicians out there to realize that these cardiometabolic screenings are the basic screenings that we should be doing. Guidelines suggested for patients, right, typically starting at the age of 20, but even when we're calculating their ASCVD risk calculator, standardly 40 and above. So as such, we have to think about these independent risk factors, these adverse pregnancy outcomes, the same way we think about the traditional risk factors. And if we do that, it does make it a lot easier. But that's where the importance is ensuring they have a primary care clinician. And that's where that handoff from the obstetrician, gynecologist to that primary care clinician is so key.
Yeah, it really is a shared responsibility.
Yes.
Well, thank you so much for shining the spotlight on this topic. I think just maybe as a final note for those who are watching, what would be the quick checklist, again, for the questions to ask if you have a woman coming in and you're thinking about cardiovascular risk prevention? What are the specific pregnancy complications?
Yeah, so in addition to screening for those traditional risk factors that we discussed, we want to think about if they did have a child, did they have any of those adverse pregnancy outcomes, the gestational diabetes, gestational hypertension, chronic hypertension, preeclampsia, premature labor that was unexplained, and more importantly, also a child that was smaller than gestational age. Incorporate that into the history will go a long way, because it will absolutely give us a better understanding of what their true risk is. So then when we do those cardiometabolic screening, we can determine if we want to do additional tests, such as those biomarkers, those risk enhancers that are laboratory tests, or even a calcium score as an example, which at a minimum will give us usually a good idea as to what their cardiovascular health is right now. And then, of course, it will also allow us to determine how aggressive we need to be in the management. Is it lifestyle only, or is there a role for additional guideline medical therapy to lower their chances of having a poor cardiovascular outcome?
Well, thank you. It's terrific. And I just hope that we can get to a point that this becomes a standard part of our question asking. So thanks again for joining me today.
Thank you. It was a pleasure.
Signing off from Medscape, this is Dr. Michelle O'Donoghue.